So, hi everybody. I'm the Chief Clinical Strategist for the Foundation, and I want to run through sort of where we are and where we're going with clinical research. You can see I both am a physician who takes care of people with Sturge-Weber, but I'm also a PhD scientist as well. And I know sometimes it can be challenging to understand a lot of the mumbo jumbo that we talk about in science. But I think you get the idea that level of detail and understanding can sometimes they use the word translate from fish or from mice to new treatments for those of us who are affected.
Wow.
Okay, everyone?
Really?
All right. Was that Karen I was hearing?
No.
Anyway, so we're very fortunate right now to have transitioned our chief scientific officer from Jonathan Pesner, who is the senior author on this original genetic paper that described the mutation, to Matt Shirley, who's now our chief scientific officer, who's on the call today. But again, this was the discovery of what the gene mutation was that caused port-wine stains and Sturge-Weber syndrome from 2013. And even though now it's been about 8 years, we still don't have a cure. And understanding a gene is the first step, but there's so much more we have to do. And there's so much we have to do to link an understanding of what we know clinically happens in the disease with the genes and what happens, particularly what I study in the brain, to cause those symptoms. So that's what I'm going to talk about today. And this is a picture of the brain of somebody with Sturge-Weber who had surgery. The leptomeningeal angioma, the port-wine stain, sits on top of the surface of the brain. So this red area, those are blood cells, because remember, blood is red. So the little blood cells are these little red spots in these tiny little capillary vessels. And that sits on the surface of the brain. The mutation is in these cells, the GNAQ mutation. But the problem is the disease that causes seizures and stroke-like episodes and headaches is within the brain itself that underlies this vascular lesion. So something that this is doing sitting on top of the brain is causing changes in this pinkish area, which is the brain you can see down here below. One of the big things that happens over time, and we have Csaba Juhász, who's sort of a pioneer in studying this on the line, is these little purple spicules, these little calcifications. They're basically little rocks that grow in the brain, and we think that they're actually not that good for you and may actually precipitate some of these symptoms, but we need to sort that out. So that interplay between what happens in the mutation, as we just heard from Nathan Lawson about, but then downstream, what happens to the brain underneath it, is what we're most interested in, because those are the symptoms that you get are coming from what's happening in the brain. So when somebody comes to me and has problems related to their Sturge-Weber in the brain, they tell me their stories. So this is Maureen. She told her, my seizures. I get this tingling feeling in my right foot. It slowly over 10 minutes rises up my leg as a wave of tingling, and afterwards my leg feels numb and weak. The feeling spreads to my arm, then my hand, and sometimes my face. Afterwards, I get so weak on my right side, but this gets better over 30 minutes or so. And then I get this pounding, throbbing headache that can last all day. So this is the symptoms. This is a sort of a migraine-like, almost stroke-like episode that we see very commonly in Sturge-Weber. And something from this picture here is causing this. And again, it's not coming from the blood vessels. Blood vessels can't cause tingling. It's happening in the brain underneath those blood vessels. Juliana's mom gave me this very long story of many things happening. I'm not going to go through everything, but she experienced migraines. She's had seizures. She got blind in her eye. She had trouble hearing, but had many brain scans. And they're really hopeful that we can kind of make sense of all these different clinical symptoms and link that to the basic science so that we can understand the disease better and come up with treatments. So Sturge-Weber doesn't stop after you're born. It continues to advance in childhood and adulthood. And actually, we don't really focus enough on adults. I mean, all of the kids who get Sturge-Weber grow up and become adults, and we need to understand those long-term effects. We're talking about COVID and the long haulers. Well, I mean, we have a lot of Sturge-Weber long haulers out there as well, and we need to work on the folks who are adults who have Sturge-Weber. And there aren't many programs that focus on adults because I think parents go to doctors when they're children's and get hooked up in the pediatric hospitals, which are very well equipped, and they get to the adult care system, and we're really not that well equipped as we are in pediatric hospitals. But this is an MRI to show what we see on a scan, on a brain scan. The white areas you see here are blood vessels. And if you see this side of the brain here, all that white that goes in and out on the surface of the brain, those are those blood vessels I showed you in that picture. You don't see those on the other side of the brain. You see them just on this side, and you can see it again here. And this is a patient at 4 years old. By 6 years old, you start seeing these white areas on the CAT scan, and those white areas, they look like the bone. Those are calcifications, because remember, calcium is in bone and here. So over time, there's a change. And there's new imaging methods that we use now that can see both the blood vessels and the calcifications. So this is an MRI that shows the blood vessels and it shows the calcifications in the brain. At age 15, we still see changes that are progressing over time. So a lot of questions come up from patients and many doctors who take care of people with Sturge-Weber syndrome. Am I having a stroke? Should I take aspirin? Is this a seizure? Why do I get so many headaches? What are the best medicines for my symptoms? Are there treatments to prevent my brain problems from getting worse? And these are really important. And again, as an adult, is there anybody out there who understands and can help me with Sturge-Weber syndrome? Things that we hear when we meet with families, when we used to meet in person, now we meet on Zoom. But again, I encourage people on the Zoom to pretend like you're in person and ask lots of questions. Interrupt me if you want to, it's fine. So when I started getting involved with the foundation, rather than doctors telling patients what they need, we asked what the doctors who care for the different areas need. What are the problems in the eye and the skin and the brain, but also the families and the people with Sturge-Weber. What do you need? What should we fix? If we could fix anything, what would you like? And we've made some good progress. So we met in 2017 in our clinical care network meeting, and many of the folks are on this call who were at that meeting, and came up with, these are our unmet needs. These are the things we need to focus on. And we really wanted to know, if we say the challenges that needed to be addressed, how do these symptoms relate to the pathophysiology? Those pictures I showed of the brain, what's changing in the brain. How do the symptoms I'm having, the strokes, the migraines, the seizures, how does that relate to those underlying changes that are going on in my brain? How does it progress, and why does it progress, and can we stop it from getting worse? And what treatments do work? You go to one doctor, some say take aspirin, you do another, you say don't. Some people put anticoagulation on because they think it's a vascular disease. What seizure medicines work, which ones don't? And all of these things contribute to quality of life. And this was something we heard from many of the families and people with Sturge-Weber is, they just want to maximize their quality of life so that seizures don't get in the way, so that they can move forward and have a normal life and not worry when something's going to happen next. Another publication from our group came out not too long ago. Amy Luat, who's I think she's still on the call now, was a senior author and first author. And what are the neurological complications? Let's really start to characterize these. And we've done the same in dermatology, and we've done the same in ophthalmology through our clinical care networks. We also have mined a registry. Many families have entered data into this large registry thanks to the foundation. And we have 2,000 participants. So this is where families would just go into the computer system and enter information about their Sturge-Weber and what's going on. Challenge of this is that often you enter at one point in time, and the disease, as we talked about, is changing over time. So there's no longitudinal data. And there's a lot of variability, and a lot of people don't know what the medical terms are So when they say it was a seizure, it was maybe not, or when they say it was a stroke, it maybe not be. So there were challenges, but we did get some useful information. And we learned that we do need newer studies, maybe going directly to the medical records, entering that data into a registry or a database. And we need to do that so that we can figure out what we should be using in terms of seizure medications, who should be placed on aspirin or shouldn't be, and hopefully develop better both abortive treatment. So if you get a seizure, we treat it, but also can we prevent the disease from progressing? Finally, another thing that came from a lot of these studies is we really need to think about that transition of care, and there's a group within the network working on this. How do we transition from childhood to adult care and make sure we get that same level of care that we got as kids? So we were happy to host, I think is our most recent in-person conference in Chicago at our institution at the University of Illinois. And we had a lot of people talking about transition of care. What do I do after age 18? These are some of the barriers. I'm not going to go into that. I think there's some other discussions either coming up or you've done them already. Okay, I see nodding. Okay. So we have a new task force, and I'm going to skip over this. But then coming back to what are we doing in clinical research? Where do we move forward? And we know there's a gene mutation. We know there's some abnormalities that change over time, and there's progression and disease progression in the brain. We know there's problems with cognition, memory, learning, seizures, headaches, migraines, stroke-like episodes, and then this goes on. And we need to think about things that either prevent the mutation or treat it early on or identify it, stop the abnormal brain development, and treat the symptoms if you already have the symptoms in a better way. And there's lots of things that are used in terms of different types of medications, but we don't really know what we're doing that well. And all of this, again, translates to the quality of life. So we really keep coming back to needing to understand what's the natural history. In other words, what to expect. If you're a parent with a young child with Sturge-Weber, you want to know what to expect. If you're a young adult and as you get older, you want to know what to expect. So we need to learn from each other. We need to learn from those who are older and those who are younger, those who have different types of symptoms, how they change over time. And that's also going to not only think about types of treatments to use, it's going to get us ready so that when Nathan and others come up with drugs, we got to be ready to do clinical trials. We got to be ready to identify those people who have those symptoms from our databases, to call them up and say, listen, we've got a drug that might help you, and get ready and know what we can measure and how we can measure things to show if you do give a treatment, how do you show you're actually getting better? If you have seizures, you count the number of seizures and show you have less seizures. If you have headaches, you have less. If we prevent the disease from progressing, we may have to have some fancy ways to do imaging of the brain, MRI, so that we can see that we're actually succeeding in the treatments we come up with. Many of you have heard of the large NIH grant, part of the Rare and Orphan Disease Program of NIH that studies brain vascular malformations. It's a consortium. We're in years 11 through 15 right now. And the goal of this study is really to get that missing clinical information so that we can get clinical trials going as soon as possible. So the project 2 on Sturge-Weber is to identify these longitudinal variables, these clinical things that happen over time in Sturge-Weber syndrome. And we are actively enrolling patients right now from a number of sites, but we're trying to expand this. If a site's not near you, we can do a lot of it by digital or a nearby center. We get baseline blood samples. We collect everything you have about yourself or can get for us from all the medical records and charts, all the MRIs that you've had done. And we get additional blood samples if you have any problems to see what happens when you have a worsening disease symptom, such as a stroke-like episode. Maybe there's something in the blood that can teach us something. And all of this goes into what we call an integrated database. A lot of databases, some contain numbers, some contain pictures, some contain, laboratory data like genes. Ours has everything together. It's an integrated database. These are the sites right now, and we're hopefully going to recruit additional sites as time goes by. But you can always just contact the foundation and identify the closest site, or we'll build another site somewhere if we can and enroll more people. We would like to get as many people as possible into the study. Here's an example of what we hope to do. You know, you go to a doctor and they look at your charts, and you know, nobody can remember what happened when you were 7, when you were 10, when you were 20. But all of this information will be on a dashboard. So you open up this computer, it'll send when you had your seizures, when you had cognitive problems, when you had headaches, and how they changed as a function of your age. We'll have all the different medications you took. Here's somebody who took the seizure medicine Tegretol. Here's somebody who took a ADHD drug, and when they started, when they stopped, and how does this relate to all those different symptoms you had? So that'll give us some ideas what medicines may actually work and which don't. And then in terms of, we said the pathophysiology, or what's the cause of things getting worse, we have all the different brain imaging that we basically upload into a server so that we can share and do analysis to see are there changes in the brain, those things we talked about before that correlate with when symptoms get better or get worse. And again, if something happens, we want to know what causes it. So that's when we collect additional information and additional blood samples. Again, all of this goes into the integrated database. And again, the goals is to identify anything from the clinical history, the brain imaging, markers in the serum that change with neurological symptoms. We need to see which treatments work, which don't. We need to understand how the disease progresses, and we need to develop and be ready to do clinical trials when drugs come out that we can start to both suppress the symptoms and prevent the disease from progressing. This sits on a computer platform that we're building at our university called Intuition, which is how we integrate all these different types of data together. Here's an example where we pull in data from the health records, from the imaging, from any tissue banked, any genes, any histology of that tissue, and it all goes into a relational database so that we can link, again, everything from the genes and the molecules to what we see on the brain imaging, to what we see on the EEGs, to what happens to you clinically, and tie it all together. So we have lots more to do. We want to get everybody involved and spread the word about enrolling in our study. It doesn't cost anybody anything. It does cost a certain amount of funds to do it. The NIH has given us money to do about 250 patients. That's not enough. We'd like to do 2,500 patients if we can. So
be very careful.
Once you build a database, you want to keep filling it. So we're looking to raise funds and to just keep, you know, filling it with information so that we can really learn from each other about what's going on and what to do. So at this point, I'm going to stop and see if anybody has questions.
Thank you, Dr. Loeb. Karen, do you have a question? Her hand's up, so I didn't know if she had a question or not.
I have a question if no one else does.
Sure, go ahead.
This is Lisa, and I'm a parent. You talked very early on about the migraine stroke-like episode with like tingling foot that moves up the leg. You just kind of use that as an example, but have you heard of multiple adults who have struggled with that?
Yeah.
Or is that a...
Yeah, kids and adults. It's
Okay.
it's kind of like if anybody gets like migraine headaches and you get the visual symptoms, you get what's called the scintillating scotoma, which is the zigzag like lightning lines that kind of grow, and you get a little bit blind on one side, and then when the vision gets better, you get a headache. So what this might be, and this might be related to these calcifications, that may cause the same thing in the part of the brain that causes sensation, as opposed to the vision part of the brain. And that's probably what it's doing. It's slowly spreading this tingly feeling up and down your limbs and your face, just as you get with people with migraines. So that's why I think it's a migraine-like symptom, something they call spreading depression. And it's not really a seizure, but it's kind of like a seizure, and sometimes seizure medicines actually do help it.
All right, that's good. Has experienced something new and it kind of fits into this. And so it's just something more that I just need to have in the back of my head as we're moving forward. But thank you for that information.
But you see, we need to get all this information in as much as we can. Actually, one of the things I'd like to add to this, and this is going to take a little bit more computer savvy, is to build a cell phone app. So if you're having, or if somebody is having a symptom, you can talk into the phone and say, I'm getting tingling in my foot. And then 5 minutes later you can say, oh, it's in my knee. And we can track all that, and we can build that story right into the database. And rather than giving it a name like migraine or seizure, we just say what you feel, and then we can put all those symptoms together. And maybe we call it something new. Maybe the word migraine doesn't work, or the word seizure doesn't work for what goes on in Sturge-Weber.
Is anybody working on an app like that?
I'm sorry, I lost the sound for you.
Is anybody working on an app currently to support that?
No, but we've been discussing it for a while. We'd like to do that. I'd like to, there's a company I'm working with right now. Maybe I can get them to help us out. And there may be other companies out there who do this.
We have kind of a general, this is Karen. Sorry, I'm getting my internet, so I'll nut it up here. We have a general kind of outline and a survey that we'll be sending to patients, physicians, anybody that, you know, might be using it, just to get a 360 feedback going on.
Other questions? Please ask.
Yeah.
Don't be shy.
And the one thing I didn't do, everybody, is Dr. Loeb, he's an adult neurologist. So please, if you have adult or transition questions, please, please, please ask today, because you've got him one-on-one right now. Excellent. Well, Dr. Loeb, I hope you'll stick around a little bit for the panel questions in a little bit.
I'm gonna have to run a little bit, but I'll take any more questions now if anybody has them. I see somebody popped up.
Oh,
Is it Sally?
Hello, isn't there already a database available like the World Health Organization and the clinical coding?
I'm sorry, a database available where?
The World Health Organization has a clinical coding team in every hospital that records this information.
Right, so there's a lot, I mean, there are a lot of databases out there. Many of them, I actually run a big database at my university where we use, as you say, the billing codes, and we collect things, but it doesn't collect longitudinal data. It doesn't collect imaging data. It doesn't bring all the different data sets together. The way we built this database that I didn't go into is we met with all of the neurologists who take care of Sturge-Weber and said, what are the important data that we need to study the brain? And then we met with the dermatologists and said, what are the important data we need to study the skin? And we met with the ophthalmologists. So this is a very special database. We'd love to work with people outside the States and share this database and add more to it because it's been really a highly curated database is very different than a big database that has lots and lots of entries but doesn't have those levels of detail that you need to ask the questions. What medicines work? You know, the timing of when you take medicine.
And that's a good point, Jeff. And there are many different types of databases out there for different things. And I appreciate you bringing up the WHO registry, because I'll be honest, I don't know that we're participating in it, and it might be something to look at. There's also something that the foundation's really trying to be conscious of is overburdening people with surveys and registries, and you know, I mean, let's face it, we got our hands full running to and from the doctor, but you know,
this is critical information. So as parents, we thought we would be 8 years in front of loading data. So if we're loading data, we need to get it out there so we can find some solutions. Because as you know, days are detrimental, and big attacks cause so much delay and regression. So we need to move forward fast.
I'm with you 100%.
Oh,
I mean,
I know.
if
Actually,
you want to talk
earlier when
further,
Nathan
I'm
was
happy
talking,
to.
I was so excited.
Yeah.
Yeah, no, it's
What did you
true.
say, Jeff?
I said we should talk more about that. We're very eager to collaborate with the rest of the world. We've been talking with centers outside the U.S. and we'd love to, share with what we've done with the rest of the world. And right, what if we could get 25,000 instead of 2,500? We would have an amazing data set. And again, every data point is something that the doctors who care for that said that's an important data point. And we have the ability to add more on downstream too to the database.